for me, if I may, just while people think about what they would like to ask, is we have this adherence issue, and it's something we really haven't talked about, and Katie talked about this morning. And it really poses this challenge to say, how do we physically remove in the first part? And the second step is then the decontamination process by whatever means, wherever it is, whether it's on the surface or whether it's now in decom, in laundry or elsewhere. So it's really fascinating the work you're doing, and I certainly will be following you in your endeavors there. It is a concern because as an environmental pathogen, it's probably the most damaging in the areas where the patients are most susceptible to this particular disease with the rates of mortality. So it's an indicator to me to the challenges we have in competency of cleaning and disinfection. It's a marker. So thank you for bringing that to our attention. Sorry, it's your floor now. I appreciate that this is your opportunity to ask those burning questions. I'm sure you've got many.
Hi, Daisy Williams, West Wales. I just have a question. You tested these products. Are you testing any other products that could be effective as a recommendation to change the policy?
Yes, so our research group is, so primarily the initial thing was what is currently being used, and chlorine-releasing agents are being used in various hospitals. So that was our first initial thought. Do these policies need to be changed? In terms of moving forward, that is the idea of testing other alternative disinfectants. And I think a lot of the problems that we face as researchers is we come from a neutral party where we haven't got any associations with any bleaching companies or any products that there are out there. You've got billion-dollar disinfection companies, and obviously when you try and utilize products of theirs, it can be quite hard to actually get those published and get that research and data to spread the awareness, really. So yeah, I think that's something definitely moving forward we are looking into do more of.
Are you looking to do any testing on the technologies that we use post-manual cleaning?
Yes, so Dr. Tina Joshi, she specialises in this, and that she has published quite a lot of research. So there's a lot of sort of genome-wide studies, and in terms of the equipment and machinery used within hospitals as well, to see if that could actually make any differences as well in terms of what is used.
Are you looking to do recommendations to be included in the standards then?
Yes, so I think the idea is we want to have these policies revisited. With all the current data and other data that's been published by other researchers globally as well, they don't seem fit for purpose. We've tried the highest concentrations of disinfectant as well as the lowest concentration of disinfectant, and it doesn't seem like this is something that's appropriate. So I think it's more of sort of prevention measures and ensuring that cleaning operatives as well, getting them involved and getting industry involved in terms of moving forward to get the best out of this, really.
I know it feels like a conversation between us, but I'm just interested that the national standards actually didn't capture technology as decontamination. So is that something that we're looking to recommend, preventative?
Technology is evolving all the time, so I think technology would be a really great thing moving forward to see what else is out there that we can use to actually optimize infection prevention control measures. So definitely something we're talking to you a bit more about as well after. So, yeah.
I think those that are older enough to remember the bad old days, it did become a problem that the government paid attention to and funded quite a lot of new research. And the Department of Health and Supply Chain at that time initiated the Healthcare Associated Infection Innovation Program. And there was quite a lot of new technology that were accelerated coming through the system. And the establishment of a unfortunately lost resource in terms of 6 showcase hospitals which were looking at the practical implementation of that. But hopefully we may come around again. We will hold our hands together and hope.
Hopefully.
Please.
Hi, my name's Alison. I'm an IPC nurse. Can I ask Elsie, the enhanced cleaning and the training and everything you did at the hospital, brilliant, by the way, did it reflect in lower infection rates? Is an IPC team monitoring, auditing what's going on? What's their future?
So IPC did it separately to us. So it's worth noting as well, if I didn't say it, I can't really remember what I said. IPC were the ones that stipulated what chemicals we used as well. So there was a massive use of Oxivir that we used, but they'd used it pre-trial, but I can tell you now, not correctly. When I asked for a bucket of Oxivir, I got undiluted Oxivir in a 5-litre bucket. So after the training, they've done 6 months of testing throughout and looking at the data that they've had of the renal patients on the ward. That has to go to the Ministry of Health before we can obviously get access to it, but happy to share the results of that as we get them.
Just out of interest, which city were you in Saudi?
We were in Riyadh.
Okay.
We do it like all over, mainly Dammam, Jeddah, but Riyadh was the main one. It was part of a trial for the whole rollout of the full Ministry of Health to actually talk about, because we train at BICS, we train from the operatives up, whereas they'd had other companies in that trained from the managers down, and by the time it got to the operatives, it wasn't happening. Or, you know, we had this lovely guy I called him Shiny Suit because he never did anything. And he got very quickly put to work. And it was just amazing, the conversations that came out of it and the difference that it made.
Yeah, no, I mean, obviously the sustainable process is actually, you know, to be applauded at making training stick, and being consistent and sustainable through a long period is actually laudable. So congratulations on a successful execution in a foreign country. Yeah.
Hello, this is a question from Mira, if that's all right, in relation to C. Again, I have been there since before C. diff was deemed to be such an issue, and the numbers were really, really high. Sodium hypochlorite, etc., being introduced in ADCCs for the control of. And the challenges have really been in practice. So the contact time, for example, of 10 minutes, no offence, but anybody who works in a busy DGH or a specialist area will know you don't get 10 minutes for contact time, and depending on what type you're using, whether you actually have to rinse it off, etc., etc. So the actual, whatever we move to in the future, it is really, really important that in practice it is possible. And nursing teams and others, domestic teams, can actually utilise it in accordance with manufacturer's instructions quite easily. And the other thing that's really important is we know that these spores can live for a long time in the actual built environment. I don't know about some of you, but my older sides of the hospital, beds being charred into the back of walls, etc., actually is the ideal ground for the spores to actually live underneath lino that, for whatever reason, has lifted the coving away from the walls, etc. And the importance of the built environment in the control of the organisms, healthcare associated, etc. Because without everything, it's kind of a triangulation that actually we're all wasting some valuable time, energies, if we can't come together and make sure the environment supports the patient, the products can be used on the environment, and of course, as always, the staff and the health and safety as well, because some of these products we have had reactions from a staffing point of view to use. So just a few things, and I will be following you as well. Thank you.
I think that's really interesting you say that, because obviously there is the practicality aspect of it as well. 10 minutes, obviously, it's not practical. But the other problem is with these chlorine disinfectants, they do have to be made up quite regularly and routinely. But some of the times, either cleaning operatives don't know the correct concentration to make them up to, and also they're not being made up as regularly as they should be. So you're using potentially expired, chlorine disinfectant. That's not really going to work because it's been made up a very long time ago. It's been sitting in the back of the cupboard. So there are definitely practical aspects of this that do need to come into play, and a lot of education around this as well.
Firstly, to get back to costs, I've started using the Francis report, because even just reading the introduction and how they were counting pennies, but looking at the consequences was quite a large part of his report, but just the introduction. But Humira, one of the issues that we've got is junior doctors wearing scrubs. Why? And interestingly, we don't have any changing rooms, or the changing rooms that we do have in the hospital that I work in are far too small, and people are expected to change in toilets. If this is actually an expectation. So with this kind of evidence and senior management unwilling to even consider larger changing rooms in a new build, where do we go?
Yeah, so this all comes down to practicality of, isn't it? So it's more the reasons of talking about this is to kind of get industry, get those in charge of management, kind of get them involved in the discussion to hopefully make those changes, really, because we've got to start somewhere. I think it's something that needs to be done.
And incidentally, we use Tristel at my trust, and our CD numbers are still higher than they should be, but we have seen a reduction with the introduction of Tristel.